Okay, well, good morning, everyone. Thanks for being here this early hour on a Friday. Today, I'm going to be talking about the Kidney Heart Service, which is a specialized consult service here at the University of Washington. I've been doing a project on it over the last year, and I'll be presenting that data today. I am continuing the theme of song titles in our grand rounds today. So I was between Every Kidney's Got a Hungry Heart and Don't Stop Diuresing, but I think relates the other way around, that every heart has a hungry kidney, and I want it to be scientifically accurate. So that's what we're going with. Disclosures, I'm a site PI for an AstraZeneca project. It really has no bearing on this presentation. So today I'm going to be talking about the development of the Kidney Heart Service, kind of a little bit of a history of that. I'll be presenting the data, which is essentially going to be describing the pre and post Kidney Heart Service. And for this project, I'll be calling it KHS. The cohort before and after KHS existed. And I'll just say up top of the hour here that this is a quality improvement project. It's retrospective. The data is all descriptive. So I'm not trying to state any causative outcomes when I'm looking at trends. We're just observing trends and seeing if there's any information we can gather there for future planning and quality improvement. So the Kidney Heart Service, I know that people who work at University of Washington are probably pretty familiar with this, but for those of you who do not work here at the Montlake campus, this is a consult service at the UW Medical Center that specializes in nephrology care that as it relates to cardiac disease, and that includes diuretic resistance, complications of mechanical cardiac support devices, and things of that nature. The Heart Institute is also here at the Montlake campus, and that provides complex cardiology care, including heart transplants within the WWAMI region. And the footprint of that has really grown over the last several years. KHS, since its inception, has provided essentially all nephrology consult service care to patients who are on primary cardiology services as of September 2020. In August 2024, so just a couple months ago, it was condensed into half of the general consult service, with the kidney liver program also being condensed into the other half. So we're at a slightly new working model right now. And also of note, in August, we launched the Outpatient Kidney Heart Clinic, which is a monthly clinic that's staffed with both a nephrologist and a cardiologist to provide specialized nephrocardiology care to patients that are identified for this clinic. In terms of trainees on the Kidney Heart Service, so when it was initially launched for the first several months, it was an attending-only service, but as of February 2021, fellows started to rotate on it. About 50% of the time, it is attending only and continued to be until the recent change in the model. In 2021, July, cardiology fellows started to rotate on the service. And then in 2022, July, residents started to rotate on the service. So we really have a lot of different trainees who come through the KHS service, including medical students as of last April as part of their nephrology electives. And then in August 2024, like I said, it used to be 50% of the time, and now because it's a combined service and there's 2 fellows at Montlake, there is always a fellow on the Kidney Heart Service. This triage guidelines is from the fellow handbook that existed from when I was a fellow, but just to give everyone a sense, if you're not at Montlake, of how patients end up on the Kidney Heart Service or another service, anyone who comes in, I actually find this flow chart a little bit confusing when I looked at it more closely, but if the primary team is cardiology, and that includes cardiac surgery or any cardiac ICU, they end up in that red box KHS. Historically, for the first few years, any heart transplants actually went to the transplant service, but within the last bit over a year ago, KHS also started seeing heart transplant patients as long as they weren't being admitted for ejection and requiring plex, in which case they would go to the transplant service. The first 3 years of the service were staffed primarily by Nan and David and Nisha. Now, Nan's no longer with us, but we'll still acknowledge him because he did do a lot of work. And then David, who's probably not here today either because he's on paternity leave, and Nisha. I started rotating on it last fall, but the data that I'm going to be presenting was from really before the time that I was on the service. One of the tools that has been developed as part of the KHS was the diuretic protocol, and this was done in conjunction between nephrology and cardiology to essentially establish a method of diuretic escalation for diuretic-resistant heart failure patients. This has gone through several iterations, and this is not the whole thing here. It's just a snippet of the page. But it's supposed to actually help cardiology teams and even primary medicine teams who have heart failure patients escalate their diuretics in a kind of dose-dependent and stepwise manner. So this has been one of the tools that's been developed as part of KHS coming into existence. So this project I'm going to present moving forward is a quality improvement project, and the purpose of it really was to describe the KHS patient cohort in terms of demographics, hospitalization details, and outcomes. We, of course, could anecdotally tell you kind of what our patient cohort was like and that they're sick and they have heart failure much of the time, but really trying to actually identify that cohort in a little bit more objective detail. And then assess for similarities and differences in the pre-KHS cohort, which was identified by general nephrology service patients who are on cardiology teams prior to the initiation of kidney heart, and then the KHS era patient cohorts. And with the hope is to potentially inform future planning for KHS through this project. And then just of note, the QI portion of this project was funded by the QI Project Accelerator through the Department of Medicine. So in terms of methods, we identified patients who were seen by KHS. An EPIC analyst through this Project Accelerator did this. Essentially any patient that was on a primary cardiology service, of which there are many, and had a note signed by a KHS-specific attending between April 2021 and November 2023, was pulled from EPIC. Approximately 6 months of the service were not pulled because the first 6 months were still in ORCA, and so we couldn't really do it across platforms. Although that was really in the early era and in the very COVID starting era, so that was also would have been a pretty big confounder back then. For a comparison cohort, we pulled general nephrology patients between January 2016 and December 2019. They were patients who were on a primary cardiology service and had a nephrology consult. And then data as relates to demographics, hospital stay, which included outcomes, procedures, and mortality, were collected and analyzed. And physician chart review, which was largely me and Nisha also very graciously helped with this, was undertaken of the KHS cohort to identify further details, including their hospitalization reasons, which were shockingly hard to pull out in just an EPIC analysis. Consult questions in terms of why we were actually being consulted, mechanical assist devices, and dialysis data. So I'll be presenting that data next, just for the purposes of this presentation. The pre-KHS cohort will be identified as general nephrology. There is more data available for the KHS cohort just because EPIC allows for more granularity in the analysis, and I did chart review for all these patients, so I will have a little bit more data for KHS. And I'll be making some data observations throughout, and then I'll at the end discuss kind of more summarization details. So first of all, who were the patients? We identified 509, 720 respectively patients between the KHS and pre-KHS cohorts. More encounters in patients, so patients could be counted more than once if they were hospitalized more than once. The mean age between the two were similar, so 62.9 versus 60. The distribution male-female was also fairly similar, 63% in the KHS, 66% in the pre-KHS cohorts. And the racial and ethnic distribution was also fairly similar. I mean, you can certainly see there are some differences here, but the trend is similar. It's majority white, and then smaller proportions of AAPI, Black patients, and really small portions of Native American unknown. Insurance coverage-wise for these patients, the trend definitely similar in terms of well above half being Medicare patients, which I don't think is particularly surprising, but I do think just of note that private insurance was much more common in the pre-KHS cohort here. And then why patients were hospitalized. So this is for KHS only. This was done through chart review, so it's a bit more granular. I know this is a slightly busy slide, but I just highlighted a few of the most common reasons. So you can see approximately half of patients were there for some form of heart failure or cardiogenic shock, which I don't think is particularly surprising. And then the next most common reasons were ACS or a need for PCI, something of that nature, heart transplant or post-heart transplant complications, and valvular disease. And people could have more than one primary hospitalization reason identified. If it was very clear, for example, if someone had cardiogenic shock from a valvular disorder, that could get them more than one primary reason. And of course, some of these listed complications could happen at any point in the hospital stay, like an arrhythmia or electrolyte disorder. It just wouldn't have been their primary reason for hospitalization. So why was KHS consulted, or the nephrology pre-KHS consulted? So this was for the KHS cohort done through chart review. You can see about a third in both pre and post were for ESRD, and then about 60% plus or minus were for AKI. And then the diuretic management, electrolyte abnormalities, and advanced CKD were all consult questions that were only identified in KHS because we just didn't have the availability to do that in the pre-KHS cohort. But you can see it just of note that about 9% of people, the primary question was for diuretic management. Again, more than one primary consult question could be identified if that was what was in the initial consult note. If someone said we were being consulted to assist with diuretics and a patient with an AKI, but generally it was based on whatever the reason was that was noted in the initial consult note as the primary question. Of course, this isn't an entirely apples to apples comparison between the two, either in the pre and post KHS cohort. I will acknowledge that. So how involved has nephrology be? So this is for KHS only, but you can see that when did we get involved in patient stay? Typically, it was pretty early. The median for when the first note was day 1. This is KHS only. And notes written by nephrology, the median was 3, but up to 43. And I think this is just a limitation here, is that someone's not registered as a nephrologist. Some notes might be missed in this data collection. But regardless, you can see there's quite a spread of nephrology notes, but that were oftentimes involved very early in hospital stays. Of course, ESRD patients were usually involved on day 0 or 1, so that's going to skew it a bit. So how sick were these patients? Well, I can tell you they're very sick. This is how many people were in the ICU. So to the middle column there is kidney heart, and then to the right, the general nephrology. Just a couple of note, basically every consult category other than advanced CKD has half or more people in the ICU at some point in their hospital stay. And also let's just say like half of the ESRD patients is also included as ended up in the ICU at some point in their hospital stay, and that's similar for both pre and post KHS. In terms of outcomes, there is a longer length of stay in the KHS service of 14 days versus 11 days. And the readmission rate was somewhat higher at 25% versus about 22%. The inpatient mortality was actually lower at 16.5% versus 25%. This is looking at that data, but in a slightly more granular way. So excuse the busy table. I'm highlighting a couple data points of note here. The highest length of stay was in the AKI groups and in the diuretic resistance groups. And then the inpatient mortality was highest in the AKI groups in both categories. I also note that there's very high 30-day readmission rates pretty much across the board. Everyone was above 20%. I actually was a little surprised by how low the ESRD length of stay and inpatient mortality was. You can see in both the pre and post era, that was the lowest in both categories. Discharge outcomes. So fortunately, discharge to home or self-care was the most common across all groups except for the AKI group. This is for kidney heart service only. We don't have the granular data for the pre-KHS era. So most people went home, fortunately, but you can see that there's exception to that in the AKI group, that less than 50% of people in the AKI group went home to self-care. And although the mortality rate was quite high, so 24% in AKI group, the rate of hospice and comfort care was also very high. And that's also true for the diuretic management and the advanced CKD group. And if you combine rate of hospice or comfort care and inpatient death, almost 45% of AKI patients are in that category. So quite a high morbidity and mortality, especially in the AKI category. Dialysis outcomes. So how many people ended up on dialysis who had an AKI? So there was a slightly lower rate of dialysis in AKI patients in the KHS era than in the pre-KHS era. And then in terms of how many people actually were still on dialysis at discharge, if they were started on it for AKI in the hospital, it was only about 7%. Kidney function trends. So this was looking at people in the KHS cohorts, creatinine trends while they were in the hospital, their lowest, highest, and discharge creatinines. And I just highlighted in yellow the medians there. So you can see that the discharge creatinine was 2.2 and the native creatinine median was 1.4. So this is suggestive that there was some residual kidney dysfunction at the time of discharge in AKI patients. And we did look at how many people have followed up in nephrology within a few months after discharge, at least in the UW system, and it was essentially nil. And we did a survey of cardiology providers to see what the reception was to the KHS service. This was done towards the end of last year. You can see these are all pretty positive, that they more likely to consult nephrology for a variety of different indications. And number 3 was actually one I was most interested in, which was, would you be more likely to ask for UF in a diuretic resistant patient? And I'm not sure how many people are just reading through this and clicking 4 or 5 most of the time. So I actually appreciated that someone disagreed with this and that the rate was not quite as many people strongly agreeing with it. But you can see that through all the questions in the survey, people had pretty positive responses, including improving consultant communication and improving their comfort in caring for patients with nephrology issues. This survey also had an open area for comments, and I'm not going to read them all out loud. They were all quite positive, but a couple of note. There's note of the attending's experience in this area. Cardiology has been extremely helpful. Someone mentioned that they had as good a working relationship with the nephrology attendings as the cardiology attendings. People highlighted the continuity of care that the KHS provides, that we're oftentimes seeing patients over a longer period of time in their hospital course than cardiology teams that are rotating off more frequently. And someone mentioned that this is unlike anything they've seen at other institutions and think it's a valuable service for the patients. I'm going to go a little bit into general observations next. I'm going to just do this disclaimer again that this is all observational and retrospective data. It's part of the quality improvement project. So I'm looking at trends and patterns, but I'm not making causative statements. And there's probably numerous reasons that any of these differences exist between the pre-KHS and KHS cohort. And I'd like to especially acknowledge the cardiology services, who are the primary services for these patients, and they're taking care of very sick patients and doing a really good job with that. And also just acknowledge that when we're involved in these patients, we're seeing this oftentimes the sickest patients that the cardiology services are caring for. So in terms of overall observations, in demographics, in both pre and post KHS, is majority male, majority white, majority Medicare, with similar income or similar insurance distributions, a little less private insurance in the KHS or more modern era. In terms of hospitalization, approximately half of KHS patients were hospitalized with heart failure or cardiogenic shock as a primary reason. And we don't have similar data for pre-KHS because the ICD-10 codes for this we found in reviewing wildly unreliable, unfortunately. The consult question was also similar in terms of ESRD versus AKI, with about a third of patients being consulted primarily for dialysis management in ESRD patients, but of note, 9% of consults to KHS were for diuretic management. In terms of their hospital course, these patients are really sick. In essentially every cohort, they were in the ICU at very high rates. So almost 3/4 of all AKI patients required the ICU at some point in their hospital stay in both the pre-KHS and KHS cohorts. The length of stay was longer in the KHS cohort than the pre-KHS cohort. This could possibly be explained by lower inpatient mortality. I'd also note that the cardiology patients here become much more complex. There's more heart transplants happening, there's more devices being used, so longer hospital courses for some of these patients is somewhat to be, I think there's plenty of reasons that you could speculate this could be the case. There was a lower mortality rate in the KHS cohort, and I do think that is notable just in terms of, again, that the patients have become more complex here. over the last several years as the footprint of the Heart Institute has grown. I'm sure there are a multitude of reasons for mortality trends. Interestingly, the length of stay was longest in the diuretic management consult cohort. I think this may reflect that these patients are especially difficult to manage. Their volume status and getting them to euvolemia and appropriate for discharge is really challenging. And if we're being asked as nephrologists to assist with diuretics as a very specific question, a lot of times that means that these patients are extremely challenging. And so I think that's probably one of the reasons that their hospital stays are the longest. And that the 30-day readmission rates were also high in every single consort category, above 20%, but that this was also highest in the diuretic management consult category, which again, I think reflects potentially the difficulty managing these patients both in and out of the hospital. Dialysis rates were lower in the KHS cohort than the pre-KHS cohort, and there's probably multifactorial reasons for this, but I do think it's notable just because, again, these patients have become more complex, more cardiac devices, more heart transplants. So the dialysis rate being lower, I think, is just a notable trend, and that most of these patients were not still on dialysis when they left the hospital if they survived to discharge. I mean, with the caveat that a lot of people did die in the hospital, their mortality rates were quite high or discharged on hospice. I do think this is notable just because as nephrologists, we like to think that dialysis and starting dialysis is under our control. So yeah, at least we like to think so. So this trend to me was interesting. In terms of kidney function, AKI and kidney function trends, AKI patients had higher discharge creatinines than nadir creatinines. And that does speak to that there's probably some residual kidney dysfunction on average in AKI patients as they leave the hospital. And that maybe speaks to a role for specialized outpatient kidney heart clinic follow-up. This clinic was launched on a monthly basis this past August and is still in the pilot phase, but we do now have a combined clinic to see these patients and have started getting a good number of patients post-discharge into this clinic. KHS is well received by cardiology providers. This is a self-selected survey. It will be the first to acknowledge it was not scientific, but the feedback was nonetheless quite positive. I think enhanced communication and improved relationships between nephrology and cardiology likely leads to improved care for these patients. I don't want to make big assumptions based on these data, but I do think that it's not really a stretch to say that specialized consult services afford closer working relationships and improved communication, and that this could reasonably lead to improved care. Having said that, it's very hard to separate those advantages from advantages of just having a better provider to patient ratio. And we have more consult services, we have fewer patients per doctor, and that also could easily lead to improved care. And I think it's hard to separate those two things. For the future, KHS currently condensed into general nephrology, so it's not, I mean, it still exists, but doesn't have quite as much specialization, you could argue, as it did when this data is reflective of. It may be interesting to trend similar data in this current year that we've changed the model and see if there's any similarity or difference in some of these outcomes. And we have an ongoing pilot currently of the outpatient kidney heart clinic, which nephrologists and cardiologists are attending. And I'd like to just acknowledge and thank the folks here, Anisha, David, and Nan, who were the kidney heart service. And when I did this chart review, it was like the adventures of David and Nan largely. So, you know, they did a huge amount of work in getting this off the ground for the first several years and really making it what it was, and under Anisha's leadership. And then the QI project itself and the data analysis, I'd like to acknowledge Lage, who was a mentor through that project, and then Ayushi, Elaine, and David, who all did analysis and statistics. So thank you for your time this morning. So the world's a bit unsettling right now, but dogs do make it better because they have no idea what's going on. These are my dogs, Ruben and Walter. So thank you for your time this morning.
All right. Thank you so much, Karen, for that fabulous overview of the kidney heart service. And, you know, I think it's really special and unique that we offer this specialized service here at University of Washington. I know our patients are greatly appreciative and have greatly benefit from it, and our colleagues, especially over in cardiology as well. So thank you. With that, any questions or comments from the audience? Got a comment in the chat from Suzanne. Karen, what a nice description of this service. Thank you. You commented that the 30-day readmission rates are high at greater than 20%. Dialysis patients in general have 30-day readmission rates of 30%. So, sounds like we're doing not so bad from the kidney heart standpoint.
True. Yeah, we should look at that as a positive. I would say that the dialysis patients, we don't necessarily have this quantified, but a certain number of patients being admitted who are dialysis patients are being admitted for a specific procedure too. Not all the time, of course, but there are patients coming in for a planned TAP or a planned PCI where you would hopefully expect that it's going to be a relatively smooth procedure and relatively fast discharge. But of course, things don't oftentimes go as expected. So,
All right.
Karen, you raised a really interesting point about the limited follow-up in clinic after seeing patients on KHS. And I'm curious why you see that to be and what could be potentially changed to help with the follow-up.
Yeah, I mean, I think, we have plenty of data out there to suggest that people with AKIs in the hospital are much more likely to end up with CKD, and having nephrology care in those patients would be valuable. And especially with these cardiology patients who, I shouldn't say especially, but certainly something we see with these patients is that when they're discharged, it can be challenging to keep them euvolemic, especially if they have residual kidney dysfunction. It can be challenging to get them on all guideline-directed medical therapy because there's oftentimes a lot of hesitancy around that in people who have residual kidney dysfunction, and maybe some fear of starting some of these medications that people really should be on. So I think having nephrology involved in those patients can be very helpful for advancing their care. And it can be hard to really get all those people into nephrology, of course, because they're coming out of the hospital oftentimes after really complex hospitalizations. They have a lot of doctors already. So getting them into another clinic, and it's not that every single patient, I think, needs to be seen by nephrology, but having that as an option for at least a certain cohort could be quite helpful. So.
Thank you.
Excellent. Yep. More praise in the chat from Raymond. Pitched a great talk, Karen. Very interesting data and well presented. And looks like we also have a question from Catherine Trite. Enjoy learning about this service. Thanks, Karen. Curious what the difference in the census is for this service compared to the general nephrology service that you compared to.
Yeah, that's a good question. It's definitely lower. The average KHS census, I think, is 12 to 15. And the general service, so it was compared to is, of course, before KHS existed, but when, for most of it, I think all of it, no, most of it, the kidney liver program existed. So that would have been a model where there were 2 fellows and 1 attending on a general nephrology service, and it would have been quite a bit bigger. So probably, I don't actually know the exact numbers of the consult census at the time, but certainly bigger. And I do acknowledge that that's absolutely a confounder here, and even ongoing, it's a confounder because, of course, when we add more services, every census gets smaller, and how much of the advantage that we might have is being seen through an effect of that versus specialized expertise.
Thank you.
Karen, great job. Quick question. So I guess aside from resource utilization, did you find any negative unintended consequences from this pilot?
That's a good question. I think the short answer is no, other than research or resource utilization. I mean, at least in these data, I mean, you could see that some trends you might argue were negative, but I don't think we can really attribute that one way or another to the service in terms of length of stay and in readmission rates. I think, the question of it being an attending only service and about 50% of the time having fellows, any negative effects of that in terms of exposure for trainees who don't get as much rotation in cardiology, nephrocardiology specific consults. I think that's been an ongoing discussion with this service. So there's certainly discussions to be had around that. But in terms of these data itself, it didn't necessarily see an outcome like that.
All right. Well, thank you so much, Karen. That was again a fabulous talk, and you know, coming from someone who trained at a different institution before coming to University of Washington, I really think this is a excellent service that we offer here. Very unique and advantageous for both our colleagues over in cardiology, our nephrologists, and our patients. So, thank you again.